Thank you very much for kind introduction and very, very learned and senior faculty, the panelists and the office bearers of Pakistan Society of Internal Medicine, President and President-elect and other people and all the delegates and ADCOs. For the last 2 days, we've been discussing really great things, novel things, new things. But today I'm going to talk about something which may not be very, very new, but it is extremely important, and it is always important to talk about important things again and again. So I'm going to talk about the role of aspirin in cardiometabolic disorders, and my emphasis would be in diabetes, because diabetes and cardiovascular disease are actually two components of one disease process. And this is the agenda. In the first part, I'll explore the aspirin's discovery and clinical uses very briefly, and then its anti-platelet action and the polymorphism and why it is important, aspirin in secondary prevention of atherosclerotic cardiovascular disease, aspirin in primary prevention of atherosclerotic cardiovascular disease, diabetes as coronary artery disease risk equivalent, and then aspirin in other conditions. So let's take up the first agenda item, aspirin's discovery. It has been used for the last maybe centuries, many centuries. 400 BC, willow bark tea was used for pains and fever and headache without actually knowing what is it that works. And Felix Hoffmann, who was a scientist working in Bayer laboratories, he synthesized purified form acetyl salicylic acid and won a Nobel Prize in 1897. So this medicine is that old and still used and prescribed almost every day by almost every physician and every cardiologist. It made Guinness World Record as being the most prescribed analgesic in 1950. Professor Samad, welcome. Please come on the stage. Mr. Chair, we just started talking about aspirin and how it was discovered and how it won a Nobel Prize. And Sir John Wayne discovered its anti-platelet action. Before that, it was used as analgesic, and they observed that those who are taking aspirin, their bleeding doesn't stop if they get a cut. So I think then they discovered its anti-platelet action, and it was this trial, international study for infarct survival, which made it a real prominent drug and first tool which we could use to prevent atherosclerotic cardiovascular disease, and it was recommended by many societies. And anti-platelet action and polymorphism, platelet has got very important role. They make a plug whenever there is bleeding. And that is a life-saving function, but sometimes when there is no bleeding, just little bit of erosion on atherosclerotic plaque, and they make a clot, and that can lead to occlusion that may result in infarction of brain or heart or any organ. So this happens through cyclooxygenase, and cyclooxygenase has got two species, 1 and 2. Aspirin blocks the conversion of arachidonic acid into thromboxane A2. Thromboxane A2 is seen as a villain, although it has got important physiological role but to prevent bleeding, but in the context of atherosclerotic cardiovascular disease, it is really seen as a villain because it promotes clotting, and we try to block it. And that we can do by giving aspirin, because aspirin can block both cyclooxygenase 1 and cyclooxygenase 2 and prevent platelet aggregation. Very interestingly, arachidonic acid actually leads to formation of two prostaglandin. One is thromboxane A2 and the other is prostacyclin. And prostacyclin is a very, very friendly prostaglandin because it comes from the endothelial cells. It has got a vasodilator action and it improves circulation. So prostacyclin has got a very favorable effect, whereas thromboxane A2 can cause ischemia. Very interestingly, thromboxane comes from the platelets, and aspirin inhibits platelets permanently. So whatever platelet is inhibited by aspirin, it would not have the ability to make thromboxane A2 because new cyclooxygenases cannot be produced because platelets do not have nuclei. Whereas endothelial cells, they have nuclei, more prostacyclin is produced. So as a result, we have selective action on prostacyclin. So we have beneficial effect of aspirin and we don't have the bad effect on thrombosis. So antiplatelet action and polymorphism, I just wish that aspirin would work on every person, but because we differ, as our looks are different, our metabolism is different, our genetic makeup is different, so many people, they have some problem with COX genes and they do not respond to aspirin, and there's no simple way of knowing. About 5 to 30%. 30% would mean every third person. Maybe taking aspirin, it might not work. But we do not know what is the exact percentage in our society, around I think 10-15%. But those who do not respond to aspirin, then maybe we might look for another agent, but for all others, aspirin is a good choice as an antiplatelet agent. So aspirin as a secondary prevention of atherosclerotic cardiovascular disease, I think there are very few things in medicine where there is almost 100% consensus. This is perhaps one of them. Secondary prevention, use of aspirin, I think in a way, if aspirin is not prescribed to somebody who has already suffered from atherosclerotic cardiovascular disease, I think that would be a gross negligence. So these are some of the guidelines: American College of Cardiology and American Heart Association guidelines, Class 1 Level A recommendation that aspirin is recommended for secondary prevention in patients with established atherosclerotic cardiovascular disease in whatever form. Whether that patient has angina or that patient has suffered from TIA or suffered from stroke or has undergone PCI or whatever form of atherosclerotic cardiovascular disease, that patient would be needed for aspirin use. Dual antiplatelet therapy is considered as only can be added to aspirin. Aspirin is always used. So aspirin is the foundation of antiplatelet therapy. In some patients, like patients who suffer from acute myocardial infarction, acute coronary syndrome, post-PCI, they are usually prescribed dual antiplatelet and then another antiplatelet belonging to P2Y12 inhibitors. Typically, clopidogrel is added to aspirin. But aspirin is always there unless patient is hypersensitive to aspirin. And the second recommendation comes from American College of Chest Physicians. And this is again Class 1 Level A recommendation. For patients with ASCVD, long-term single antiplatelet therapy with aspirin or clopidogrel is recommended. For majority aspirin, for those who are intolerant to aspirin, they could be given clopidogrel. And again, clopidogrel also doesn't work in 100% of the cases. That is why sometimes we give a combination. Dual antiplatelet therapy is generally not recommended over single therapy. So you have to have a reason to prescribe dual. I think the main reason is acute coronary syndrome or PCI. And we try to give it for maybe 1 year, and then we try to come back to single. And third recommendation, European Society of Cardiology, again Class 1 Level A recommendation for patients with ASCVD, aspirin 75 to 100 milligram daily is strongly recommended. Clopidogrel 75 milligram daily can be given if aspirin not tolerated. So you will always try aspirin first if somebody is intolerant, and aspirin is much cheaper also. So this is just a brief summary of the evidence we have in favor of this drug, so I will not go through. These are the studies on the basis of which all three major societies have given 1A recommendation to aspirin as a secondary prophylactic drug. So mostly if dual antiplatelet therapy is ever given, and this is how we go about it, aspirin and clopidogrel, both 75 milligram, usually for 12 months, maybe longer duration, maybe shorter, depending on the patient's tolerability and the indication. And then we usually continue with aspirin alone. And clopidogrel may be continued only if aspirin is contraindicated for some reason. But most patients, I think, are treated with single agent, and the single agent is aspirin, and that is usually for life. Because we always want to prevent the second or the third attack, so aspirin is usually for life. Now let me examine the aspirin in primary prevention of atherosclerotic cardiovascular disease. I think data may not be that strong, although there is conflicting evidence. I'm going to go through this recommendation. First one, if people more than 60 years, as a routine, it is not recommended. There was a time, I think 10 years, 15 years ago, there was a time that people were saying that everyone should take aspirin. I think we cannot make that kind of bracket statement, but those who are more than 60, they need to have a reason. Otherwise, younger patients, 40 to 60 year, if those people have atherosclerotic cardiovascular risk calculated more than 10% in 10 years, they are good candidate for aspirin. And American College of Cardiology, American Heart Association, they say low dose aspirin may be considered in select patients 40 to 70 years at high risk of CVD, but not at increased risk of bleeding. Those patients who have CLD, those who have active peptic ulcer disease, proven bleeding, I think they should not be given as a routine. Others should be given if they fall in a high risk group. European Society of Cardiology recommends against routine use of aspirin in individuals without CVD. So I think it is individualization. I think that is where my emphasis would be, and that I'm going to cover in next slides. So diabetes as coronary artery disease risk equivalent. Diabetes is not just hyperglycemia. Diabetes is bad because it kills through atherosclerotic cardiovascular disease. 70 to 80% morbidity and mortality is related to heart attack or the stroke or the gangrene. So we are very, very worried and very concerned about this. So this is the study, I think the two studies, both of them, they proved that having diabetes or having suffered from cardiovascular disease, there is equivalent risk of having subsequent coronary artery disease, coronary events. So you can see that, yes. So on this basis, there was a very important quote or statement that having diabetes is as if you already have coronary artery disease. So later on, it was realized that that is perhaps an overstatement. I think I would say having diabetes of approximately 10 years, and especially with additional comorbidities, is just like having coronary artery disease. So we should treat them as if we are treating them as for secondary prophylaxis. So this is the little more explanation, and you can see that atherosclerotic cardiovascular disease complication, they actually start developing before the diagnosis of diabetes is made at a hemoglobin A1C of 6.5. So actual process which culminate into diabetes, that starts 10 years before that, and that is the time when people have already started developing atherosclerotic cardiovascular complication, whereas microvascular complication, they typically start once diagnosis is made. I think because they're more closely related to hyperglycemia. So diabetic patients are at odd. I think they are 3 times more likely to develop atherosclerotic cardiovascular disease, 3 times more likely to develop a more complicated form and not able to having a procedure, and then 3 times more chances that the procedure will fail. So at every level, they are, I think, worse off. So why it is so? Because diabetes is not just hyperglycemia. Diabetes is actually a complex disease. In the center, of course, is hyperglycemia, but we have hyperlipidemia. It is, I think, almost impossible to see a type 2 diabetic patient who has ideal lipid profile. If not hyperlipidemia, he would have some kind of dyslipidemia. His triglycerides are high, HDL is low, or LDL particles are functionally abnormal. And many of them, they have hypertension. You all know that the cut point for the diagnosis of hypertension and diabetes is different. And then truncal obesity is again almost a universal feature type 2 diabetes. Then these patients, they have pro-thrombotic and pro-inflammatory state that can also predispose to clot formation. And then endothelial dysfunction is very, very common. And unfortunately, anti-diabetic medication, anti-glycemic medication does not correct all these associated abnormalities. Although when we choose a glucose-lowering therapy, we do consider that there should be agent which should address this all, but we mostly have to give additional therapy. For blood pressure, we have to give ACE inhibitors. For cholesterol, we have to give statins. But I think aspirin is also one of the strong candidates to minimize the risk of developing cardiovascular complications as a primary prevention. So risk of having aspirin has, of course, downside. It can cause intracranial hemorrhage. It can cause gastrointestinal hemorrhage. Risk of having these complications is almost same. When you start, you have the same risk, but risk of other complication, atherosclerotic cardiovascular complication, that increases with duration. So as the time passes, the chance of developing atherosclerotic cardiovascular complication increases from mild to moderate to severe. For example, this is a patient who is just newly diagnosed. I think his risk may be equivalent to a non-diabetic. We often see patients in the ages of in the 20s, in the 30s, coming with diabetes. So their risk may be just equivalent to non-diabetic. But on the other extreme, we have patients who have multiple comorbidities, known cases of ischemic heart disease. They have suffered from PCI, ischemic heart disease, CVA, I think in left extreme, decision is easy. Perhaps they do not require routine use of aspirin. On the other extreme, I think almost all should get aspirin, but where your deliberation is needed is this third phase, the intermediate phase, diabetes of long duration with hyperlipidemia or dyslipidemia, with hypertension, obesity, smoking, family history of ischemic heart disease, but no known ischemic heart disease. This is where you have to individualize. I think if somebody has a relatively shorter duration without any comorbidities, you may decide against, but those who have a longer duration with 1 or 2 or 3 additional pathologies, you would probably decide in favor of prescribing aspirin. So this is the basis of the calculator. One way to decide if you want to prescribe aspirin or to calculate their 10-year risk. And this is the formula. I'm not going to go in the detail. App is available. You just feed in the required information. You will get the required risk. So it could be low risk, less than 5%. It could be 5 to 7.5%, borderline, then intermediate, 7.5 to 20, and then high risk patient. High risk patient should get aspirin. I think intermediate patient should also get aspirin. The other two categories you can individualize. So this is a case vignette. I think I'd like to have your opinion. It's a 68 years old male presents with following: long-standing diabetes, 15 years, hypertension, 10 years, hyperlipidemia, 10 years, obesity, BMI of 32, and smoking 30 packs years, current HbA1c 8.9 and creatinine 1.7, but he does not have a known coronary heart disease, no clinically manifest coronary heart disease. What are your ideas about this? I think this patient has got 10-year atherosclerotic cardiovascular disease, approximately 100%. And aspirin is justified, I think, in this case, unless contraindicated because of some reason. So aspirin, I'm coming to end of my presentation. I know you are, aspirin, another condition, it's a magic drug for cancer prevention. Number of studies have shown or indicated its ability to prevent cancer, especially colon cancer, but it is not formally recommended for the cancer prevention. Alzheimer's disease, it could prevent, and pregnancy, of course, the next speaker is going to highlight that. So these are some of the side effects. Everything in this world has a downside. Very few people, they have these side effects. I think otherwise it's okay. So summary, as aspirin is antiplatelet therapy. Aspirin is a first-line antiplatelet drug in most situations where antiplatelet therapy is required. Very effective in secondary prevention. Not prescribing would be actually a sin. Unanimously recommended by all society, given 1A status. Individualized decision for primary prevention, risk-benefit ratio favorable in high-risk patient. Most diabetic individuals with multiple comorbidities should qualify. Great value for money, and aspirin has rightly earned the label of a wonder drug. Thank you very much.